Shows.
Okay. So I want to welcome everybody tonight to Hope Connections educational program, Bladder Cancer Update with NIH physicians. And it's my pleasure to introduce our speakers, Dr. Elias Chandran and Dr. Raju Shellery. Dr. Chandran is a medical oncologist with specialist experience and interest in bladder cancer. He also has specific interest in mismatch repair deficiency and microsatellite instability. His research is focused on development of new therapeutic strategies for these malignancies, including the novel use of immunotherapies and investigational therapeutic agents such as antibody drug conjugates. After graduating as a medical oncologist in New Zealand, Dr. Chandran came to the National Cancer Institute at the National Institutes of Health in Bethesda, Maryland, to undertake a 2-year advanced fellowship program in genitourinary malignancies, focusing on bladder cancer as well as prostate cancer, under the mentorship of Dr. Andrea Apollo and Dr. Ravi Madden. In 2023, Dr. Chandran accepted the position of assistant research physician in the bladder cancer section of genitourinary malignancies branch at the NCI. Dr. Raju Shellery is an attending surgeon in the urologic oncology branch of the National Cancer Institute and is the head of the bladder cancer section. He trained in urologic surgery at the University of Pennsylvania and completed his Society of Urologic Oncology Fellowship at Fox Chase Cancer Center, both in Philadelphia. He is experienced in complex surgical management of genitourinary tumors with focus on urothelial malignancy of the upper and lower urinary tract. He specializes in the surgical treatment of bladder cancer and performs endoscopic, robotic, laparoscopic, and open surgery such as radical cystectomy. He is proficient in providing a wide variety of urinary diversions such as ileal conduit or neobladder. Dr. Shellery is extremely dedicated to his patients and ensuring they receive the highest quality care and fostering open and frequent communication, which I know we all love. He has authored over 30 manuscripts and book chapters and regularly presents at national and international conferences. And we are so thrilled to have you both here with us tonight. So I'm going to turn it over to you. And again, my apologies for any mispronunciations.
No, you did fantastically. Thanks for the introduction. So I'm Elias Chandran. I'm one of the, so I work in the bladder team in the NCI. I work with Dr. Apollo, which I'm sure many of you would have heard of before. So I prepared a talk today with Raju, but I'm really not going to be going into too much detail. We're kind of just providing a high-level update of the treatment and just some kind of, I suppose, some background information about bladder cancer as well. So I hope that will be useful. I just wondered, like, among the attendees, are we having patients with newly diagnosed cancer, or family members, or patients who've had it for a while, or I heard in remission as well. So is it a mix of
It's a very broad mix of T1, T sub 0 up to T3s with the surgeries associated with those various areas, and with immunotherapy, chemotherapy, and related.
I'm newly diagnosed.
Okay.
Non-muscle invasive.
I see.
Would it be in the interest of providing whatever is of most utility, would it be helpful for us to kind of go through slides, or would it be easier if we have a conversation and answer questions? What's the best for everybody?
I can. So we have prepared some slides, and we're focusing our talk tonight mostly on muscle invasive and metastatic disease, but we can answer any question. I mean, Dr. Chaluri is more proficient with non-muscle invasive bladder cancer, so I'm sure he'll be happy to take questions about that. But what we can do is we can just go through the slides quickly. I won't spend too much time on them, just to give you some information, and then we can have a discussion afterwards.
Great idea.
Okay, so I'm going to share my screen. Let's see. Are you seeing my screen?
Yes.
Yes.
Okay. So, yeah, as I mentioned, muscle invasive and metastatic disease. So just to give you a bit of background, oops, I don't know why that went back. Bit of background, urothelial cancer, urothelial carcinoma. It used to be called transitional cell carcinoma, but we don't really use that term anymore, but you'll see it in old publications. It's called bladder cancer. The generic term is bladder cancer if it's arising in the bladder. But it's also known as upper tract urothelial carcinoma if it's in the upper tract, which we define as this region here between the ureter to the renal pelvis, which is the collecting part of the kidney here. And rarely patients can get the same tumor in the urethra as well. And it's called a urethral cancer. So this whole urinary tract, has the same lining. It's called the urothelium. So urothelial cancer arises from the urothelium. The biggest risk factor is smoking, but there can be occupational exposures to certain chemicals that can increase the risk, like aniline dyes is well known about. And rarely it can be due to an inherited gene disorder like Lynch syndrome. And the staging of bladder cancer, I'm sure many of you know this already, but just to kind of give you this information. So a urothelial carcinoma arises from the inside surface of the bladder. So that's the urothelium. And so it ranges from CIS, which is usually a flat lesion that's in the surface of the bladder here, to a TA or T1, and these are considered non-muscle invasive. When it's a T2, it's invading into the muscle layer here. So T2, T3, and T4 are considered muscle invasive. T2 goes into the muscle layer, T3 goes beyond the muscle layer into the fat layer, and T4 is when it breaks through the fat layer as well, and maybe invading an adjacent organ. And the staging system, so that was the T stage that I was going through. We used the TNM staging, which is tumor node metastases. So that's the T staging. And then N, so if there's a node that's positive, that's an N positive tumor. It could be N1, 2, or 3, depending on how many of these local nodes there are. And then there's the M stage, which stands for metastases. And if there is any spread of the tumor to anywhere that's distant, like lung or liver, then it's M1. And so you'll often hear people saying stage 4. That's the overall stage. That's not referring to just the T stage or anything. If it's a stage 4 tumor, usually in Latin numbers like this, that's a combination of all the T, N, and M. So stage 4 usually means M1. Okay, but in bladder cancer, we don't typically use the overall staging so much. So we rarely ever say a stage 2 cancer or a stage 3 cancer. That staging system is used more in other tumors like bowel cancer, but not so much in bladder. So we tend to just describe the T and N typically. So we'll call it like a T2N1 or a T2N0, because it's easier for us to be more specific that way. So talk about muscle invasive bladder cancer now. With muscle invasive bladder cancer, because it's invading the muscle layer, that layer has a very rich blood supply. So there is a high risk of distant spread of the tumor. But it is curable. and the gold standard treatment is removal of the bladder, and that's by cystectomy. Okay, if it's an upper tract tumor, then it's removal of the kidney and ureter. It's called nephroureterectomy, and Dr. Chillery will go through these in more detail. We often give chemotherapy. Well, it is the standard to give chemotherapy pre-surgery. So that's called neoadjuvant chemotherapy, meaning before surgery. We give it for about 3 months. The main drug that's still given is called cisplatin, and it's combined with other agents such as gemcitabine. More recently, in the last few years, we're also giving immunotherapy because it's been shown to improve survival. And not everyone can get cisplatin. It can be a toxic drug, and so patients need to be well enough to receive it. So some of the eligibility criteria for cisplatin would be having adequate renal function or kidney function, having good general fitness, which we call performance status, and they shouldn't have they can't have significant neuropathy, which is nerve damage from. It could be, some people can have neuropathy from diabetes, for example. If it's really severe, the cisplatin can definitely make it worse, so they wouldn't be eligible. Or having severe hearing loss or heart failure. And if patients are ineligible for the cisplatin, then they just proceed straight to surgery. We wouldn't give them a different chemotherapy preoperatively. Some common side effects of cisplatin, in chemo in general, causes immunosuppression. It can cause low blood counts. It can cause problems like mouth sores, heartburn, constipation, diarrhea. But specific to cisplatin would be the neuropathy. Hearing loss. It can cause hearing loss and tinnitus as well, which is why you can't have this before having the drug because it will just make it worse. And it can cause kidney damage as well. So patients need to have a minimum level of kidney function to be able to receive cisplatin. So I'm immunotherapy in muscle invasive bladder cancer. So I have this link to a YouTube video, but it's not going to work, unfortunately, tonight because my NIH system doesn't allow me to link the video into the presentation. So I'll just describe. I'm sure many of you would have heard of these drugs here: Keytruda, Opdivo, Imfinzi. These are called immune checkpoint inhibitors. So in the immune system, I'm talking, and there are these specific cells called T cells. They patrol our bodies, and their function is to kill cells that are abnormal. So they kill cells that are abnormal because they're infected by a virus, or they can kill cells that have mutated to become abnormal due to a cancer, for example. And so the immune system is vital in controlling cancer from developing. And in patients who have there are some conditions where they have an impaired immune system, they have a higher risk of developing multiple types of cancers. But when a cancer becomes apparent, once it learns to escape the immune system by pretending to be a normal cell. So it uses this molecule called PD-L1 to camouflage itself as a normal cell. So the immune system the T cells go to it, but they don't kill it because they think it's normal, because it puts out this false signal. So these drugs here, they block that signal, that PD-L1 signal. So they remove the camouflage from the cancer cell, and then the immune system is then able to recognize them as a foreign entity, and they kill the cell. So that's how they work. Their side effects are very different from chemotherapy. So they don't cause the immunosuppression that you see with chemotherapy. They instead, they can cause because we're activating the immune system can attack normal body parts. So it can attack the skin, it can cause a rash, it can cause a thyroid inflammation, any part of the body really. So pneumonitis is when it causes inflammation of the lungs. Colitis is when it affects the gut, and hepatitis if it affects the liver. And if any of these occur, these are usually due to inflammation, and so we have to reduce the inflammation. We typically give an immunosuppressive drug to treat it, like a steroid. And immune checkpoint inhibitors can cause general side effects as well, like fatigue, nausea, loss of appetite. So that is, I would say, the gold standard treatment of bladder cancer. I talked about removal of the bladder, with chemotherapy before removal of the bladder, and immunotherapy to follow. There is an alternative to that, which is bladder preservation. Now that's very attractive, for patients, of course. For now, it hasn't been compared head to head with surgery because it's just impossible to design a trial like that would be acceptable. And we have less data for long-term outcomes for bladder preservation strategies. So one of the most most used, I guess, bladder preservation strategy is concurrent chemoradiation. So that's giving both at the same time. And it may be considered in select patients. So there needs to be ideal conditions for this to be effective. So number one, there can't be a blockage of urine outflow from the kidney. So there can't be hydronephrosis. So this on the right here is hydronephrosis. You can see this kidney swollen. The cause in this picture is not clear, but for example, if there's a bladder tumor here, we worry that it's going deeper than the muscle layer if it's causing hydronephrosis. So we reserve this chemoradiation treatment for patients with lower, like smaller tumors. So they need to have a T2 or early T3 disease. And the tumor location needs to be amenable for complete TURBT. So this is when they scrape out the tumor cystoscopically. There cannot be extensive CIS. CIS is that flat layer of cancer on the inside of the bladder wall, as I mentioned. So there cannot be extensive CIS, and the patient needs to have good bladder function as well. So this is what chemoradiation is, or bladder preservation is also called trimodality therapy. So the patients have a maximal TURBT first, where they scrape out the tumor, and then they undergo chemo and radiation. There can be, there can be significant side effects from this treatment too. So because the bladder is radiated, it can cause bladder irritation. So it can be bladder spasm. It can cause long-term urinary frequency and urgency. And the rectum is right behind the bladder, so it can cause rectal inflammation as well. During the treatment, it can cause fatigue, and it can cause sexual dysfunction as well. But there are lots of because bladder preservation is obviously very attractive for patients and doctors alike. So we're developing new strategies, but at the moment they're in clinical trials. They're not standard treatment yet. Okay, and then I'll talk quickly about metastatic disease. So that's also known as stage 4 disease. So metastatic disease, unfortunately, is not curable, but it can be controlled with systemic therapy. And we have very effective treatments these days. So we have new treatments, and life expectancy has improved considerably. Something really important to have, which is now standard for patients with metastatic disease, is genetic sequencing. It's often referred to as NGS, or next generation sequencing. So often we just say NGS, but it's also called DNA sequencing, genetic testing. It's all the same thing. And these are the different platforms: Foundation, Altera, Tempus, etc. And it's really important because it can help to identify a mutation that we can target, which I'll talk about next. And the other thing that is pretty widespread now is using ctDNA, or circulating tumor DNA. So I'm sure many of you would have heard of this. It's using a blood test to monitor tumor DNA, and the utility would either be to test that DNA for any mutations, any target mutations. That's especially if the tumor is really hard to biopsy. For example, if it's like a bone metastasis that can be very hard to biopsy, so we might elect to do a blood test instead to look for the tumor DNA. And the other utility is to monitor the ctDNA levels with therapy. So this could be with metastatic disease or patients post-surgery. Just to give you an example, this is a patient of mine who had surgery in June of 2024, and he had high-risk disease. Initially, ctDNA was high, it was 30. And then he started on immunotherapy, and it went to 0. And it's maintained at 0. And his scans so far have shown no evidence of disease. So this is, it's a nice way to monitor patients. The only problem is that we're not, I feel like even though we use it a lot, if it comes back positive all of a sudden, that can be a very difficult situation, because it can cause a lot of anxiety. So if the test would have become positive, what we would do is then we may do an earlier scan or something, but the scan may not show anything, even if the ctDNA comes back positive. And if the scan doesn't show anything, then we don't give chemotherapy. We don't give any of these treatments. We typically would scan them again later on. And just knowing that result, can cause a lot of anxiety in patients. So that's something to keep in mind when you think about having Signatera or any of these ctDNA blood tests. Like, do you want to know before the scan shows anything? So yeah, as I said, may not change management. Okay, I'll talk about EV Pembro, because this is the most effective treatment we have now for metastatic bladder cancer. So it's EV with EV is enfortumab vedotin. Pembro is Keytruda, and it has surpassed chemotherapy as the best first-line treatment. It significantly improves survival. It has doubled life expectancy in patients with metastatic disease. And some patients are in durable responses, so lasting more than 3 years, 3 years and counting. So because it's so successful in the metastatic setting, it is being studied in the muscle-invasive setting now. So it may change the treatment in the muscle-invasive setting in the future. Because in the past, like I was talking about cisplatin being the standard therapy for muscle-invasive disease, that was the standard for metastatic disease, but it has been replaced by EV Pembro. So EV is a very this is a very elegant molecule. It's got 2 names because it's made out of 2 drugs. So there's an antibody, and which is the green part of the molecule, and there's a red, the chemotherapy, which is the red thing. The antibody will latch on to a protein on the surface of the tumor called Nectin-4. And then the tumor will internalize the molecule, and the chemotherapy gets released inside of the cell, and this kills the cell. So it's a targeted chemotherapy essentially. But it can cause side effects as well. So I won't go into too much detail. I think I don't want to overload everyone, but the most common side effects would be rash and neuropathy. And the difference between EV Pembro and chemotherapy is that chemotherapy would be given for a set number of cycles, usually 4 to 6 cycles. but EV pembro is typically given continuously. So these side effects can become worse with time. So we're still learning how to give this, and we now often would put patients on a break from the EV after 6 months, just to prevent, especially the neuropathy, which can be debilitating. So we want to avoid anything like that. So we put them on. We plan to put patients on a break after 6 months, and we find that the response is often maintained with just continuing the pembro, and we mitigate some of these severe side effects. Okay. So after EV pembro, we have a lot of treatment options these days. We would go back to that the platinum-based chemotherapy. There are other treatments. There's if you have HER2 positive disease, there's a specific drug. If there's an FGFR mutation and this is tested by NGS, there's a specific drug called erdafitinib. There are other chemotherapies. So I think I might skip over this. This is just to show how this is just another antibody drug conjugate called HER2 that targets HER2. So let me see. In the interest of time, I might finish here because I think I've covered most of, I think, metastatic disease now. So I will give the floor to Raju Chaluri.
Well, before we keep going, did anybody have questions or anything we can clarify or talk about?
Are these treatments generally available at most major hospitals, or do you have to go to specific institutions like MSK or
They are available. So EV pembro is now FDA approved, so it is available in any institution. The other drugs I've presented today are all standard treatments, so they are all available in any institution.
Wonderful.
May I ask a question about one of your earlier slides about the cause?
Yeah.
I saw smoking was listed as the first. I'm assuming that includes either direct smoking by the individual or secondhand smoke?
Yes.
Yes, it would. Yeah.
Okay. All right. Thank you.
It wouldn't be the same, if you have two people, one person smoked the cigarettes for 25 years and the other one was exposed for 25 years. It's not 100% equivalent, but we do always ask that question.
Okay. Thank you.
Any other questions?
Ms. Sa-
Yeah. So how does anyone find out if they're eligible for some of these things, which we haven't heard about from Bob's urologist?
So if someone has muscle invasive disease or metastatic disease, often you get referred to a medical oncologist. So medical oncologists give these medications. Urologists often do that. They do the surgery, and they are more involved in the non-muscle invasive setting where they give drugs into the bladder. But once, especially if we're treating with if we're worried if the tumor has spread outside of the bladder, then we need to give treatments that are going to be infused, so systemic therapies. So that's when you see an oncologist.
What stage is his tumor? Maybe that question was missed.
We don't have to share personal details, but
because it might, if he's seeing a urologist, and he might not have, depends on the clinical scenario of what is his disease burden. Some of these might not necessarily be the correct medicine for what he has, I suppose, is what I'm trying to say.
There's a question.
Is that all right?
Yes. Yeah.
What is the range of locations that you find metastatic bladder cancer? I seen on your picture you had a picture of the lung, and I can't remember where else. Is it
Okay.
ever in the thyroid gland? Is it ever in the brain? Is it any just basically what?
Most commonly, we see it varies, and there are different subtypes of cancer that go to different places. But we often see disease in the lungs, in the bone as well. That's quite a common place for it to go. We also see patients with liver metastases quite often. Other areas are less common, and also, of course, the most common actually is lymph nodes that are outside of the pelvic area. So it could be lymph nodes in the chest or higher up in the abdomen. So that's very common. And then after that would be organs like the lungs, the liver, and the bone. It doesn't go to the brain as commonly. It can happen, but we don't see that very commonly. And it can go to other unusual places as well, but that would not be as common.
Pancreas and salivary glands, or
That would be rare. Mm-hmm.
thank you.
Yeah, no problem.
I've been dealing with non-metastatic bladder cancer for several years. Is there a common
Where's Tucker?
movement from non-metastatic bladder cancer to metastatic bladder cancer?
It depends on the stage of the non-metastatic. So if it's non-muscle invasive, which is a T1 or less, the risk of it becoming metastatic is lower compared to patients with muscle invasive bladder cancer. That's when it goes into the muscle layer of the bladder. That has a higher risk of metastasizing.
So far,
That's why if it's muscle invasive, we remove the bladder. There are some, but it's a little more nuanced than that. There are some patients with non-muscle invasive where we do remove the bladder as well. But in generally speaking, in terms of the risk of it going to other places, that's why we remove the bladder for muscle invasive, because there's a high risk of it metastasizing.
Thank you.
Should I go ahead and pull up some slides?
Good idea. Yes.
One moment. And certainly, feel free to just ask questions. I think it's certainly more fun and more engaging when people it's more of a conversation. So I'm gonna, let's see, share here. So how's this looking?
Yeah, looking good.
Good. How do I keep? I can't. I guess we
maybe use the panel on the side and just go to your slide first. So go to.
No. What I was trying to do is see if I can keep the faces up. But
I see. No, you can't.
Yeah. So first of all, hi. It's wonderful to speak with everybody. And I'm Raji Chiluri. So to Dr. Chandran's point, I'm the surgical side of things. And like I said, I think a lot of this is to answer questions and provide whatever we can to, make everybody feel more in understanding of their diseases. So please feel free to interrupt and we can go over anything that, I don't know, anything that comes up. So I thought we could talk about muscle invasive bladder cancer. And a lot of this will be in terms of the historic kind of surgical management and what people can expect. There's a lot of new research, not only in how to do the surgery, which is a little less novel, I suppose, but also to Dr. Chandran's point about bladder sparing. And there's certainly a lot of debate in our community about making sure that we're doing the safest thing while also trying to balance the quality of life concerns and making sure that we're offering the best treatment while minimizing the risk. So these are kind of what we're going to go through. What is muscle invasive disease? How do we treat it? Some of the components of the surgery, and I think most importantly for patients, is to understand what the urinary diversions are, how we rebuild the urinary tract, and then briefly to talk about the surgical management of upper tract disease. And if there's time and interest, we can certainly go into some of these new therapies that we are trialing to avoid removing the bladder. So we were talking about staging, and I really like this picture because it elegantly cartoons what a bladder looks like in cross section. So we have all of these layers. This layer here is the innermost layer, what we were calling we said that the transitional cells are not what they're called anymore. We call them urothelial cells. So we have this layer here. This is the layer that's in the contact with the urine. Below that is what we have is called the lamina propria. That's kind of the intermediate layer and the connective tissue layer between the innermost layer, which is where the urine kind of bathes these cells, and then the muscle of the bladder, and that's where the contractile function of the organ comes from, that allows urine to be expelled out. And so when we're talking about muscle invasive disease, these are the layers into which the tumor cells are infiltrating. Now, this is important because you can almost imagine that this layer is within the layer itself, right? So if you have a tumor here, it's just within the innermost layer. This layer is kind of sturdy and strong. And so once tumors are able to infiltrate into that area, it's very challenging for us to fully be able to remove everything without taking out the entire organ. So muscle invasive disease, so this is still what we would call localized cancer, meaning that there is not spread of this cancer to other areas of the body. It's just located within the bladder, but it's of such concern cellularly that we think we have to take everything out. So when we have muscle invasive cancer, what do we do? Actually, in preparation for this talk, this is the first original description of the surgical technique for removing a bladder. It was in 1950. But fundamentally, what we do is we remove all of the organs that are in close relationship anatomically with the bladder. And that's different in men and women. And so in a man, we'll take out their bladder and their prostate. In women, we'll take out the bladder, and there's some debate in the surgical community about how much of the gynecologic organs need to be removed. Historically, we would remove everything, but in the interest of quality of life and maintaining endocrine and sexual function, we're trying to figure out what is the safe way to leave as many of the gynecologic organs in place while safely removing all of the cancer. And so, it's kind of is there a question? Sorry, I don't have like the little faces, so I can't tell, but if there's a question, please go ahead.
I'll monitor too, and people can put something in the chat if you have a question too, but thank you.
Okay, great. So, the fundamental of the surgery is we remove the surgery, and then, like I said, we rebuild the urinary tract. And so classically we do what's called an open radical cystectomy. And so this is the typical incision that we make in the skin. Actually, this is a historic picture, and the old way would be to make this incision all the way up here, but not these days. We typically make a small incision underneath the belly button going down to the pubic bone. And we do two things when we do the removal. We do a lymph node dissection, to Dr. Chandra's point about the most likely place that tumor cells can go. And then we remove the bladder itself. And so I have a lot of pictures from some of these kind of surgical atlases that describe to trainees the things that we do. And I think that it very nicely illustrates kind of what happens when you're undergoing this surgery. So this is a picture of what a lymph node dissection looks like. And so essentially you have these big blood vessels in the body, and you can see this yellow kind of tissue here. This is what the lymph nodes look like when we're doing the operation. And if you follow the red arrow over, the same anatomic areas are in the cartoon, but this yellow area is no longer in here. And so when we're doing this lymph node dissection at the time of the surgery, we do it on both sides of the body and take out a variety of lymph nodes from different anatomic areas. for both diagnostic purposes, but also for therapeutic purposes. So it's important to know if there's cancer in the lymph nodes. But in an ideal world, in removing the lymph nodes, we're removing any microscopic cancer cells that would be in there. And, without diving too much into what we do, essentially, this is a picture of a human. We're looking at it from the side, and this is in a male. So we're going from, one hip bone to the other. What we end up doing is, if this is the urinary bladder and this is the prostate gland, this is the rectum down here, is we end up coming around and removing all of this in one piece. And that's why the surgery is called a radical cystoprostatectomy in men. In females, it's historically called an anterior exenteration, because we'll take out the gynecologic organs. But fundamentally, the point is that we take out the bladder and the tissue, the organs that are in the closest proximity to the bladder, along with some. Again, for the patients, this is of less, I suppose, when you wake up, the things are gone. The more important thing is, how do we rebuild the urinary tract? And what can you expect from that once we do the rebuilding? And so I can pause here really quick. Are there any questions or anything, or should I keep going?
Keep going. This is really great.
Yeah. So how do we rebuild the urinary tract? So the way I explain it to patients is, we rebuild a urinary reservoir, which means that the urine has to go into something, and then that something has to be able to expel the urine. And I'll have a lot of pictures that'll show all of this. But fundamentally, we have a non-continent diversion, which means that the urine comes out without your control. And then we have a continent diversion, which means you're able to hold the urine in your body, and then it comes out when you decide it should come out. Now, the reason that I have these kind of car designations is, it's really simple to think, all of us kind of know what a Corolla versus a Ferrari is, right? So Corolla it's reliable. They're everywhere. If you have a problem with a Corolla, anybody can fix it, and you know that it's going to work. Ferraris are awesome, right? Everybody wants a Ferrari. But if the Ferraris can have lots of issues with them. And B, if you have a Ferrari and you have a problem, it's not like you can go down the street and have anybody try to fix your Ferrari. So the continent diversions are, when they work great, but there's a lot of kind of risks, and you have to understand potentially what you would be getting yourself into, because fundamentally everybody would want a continent diversion, right? But the problems that are realistically with them will sway a lot of people. And fundamentally, I actually think the best diversion is a non-continent diversion. It's just the safest and it's reliable. So let's talk about what a non-continent diversion is, which is an ileal conduit. We were talking about that earlier. So this is a picture of a human, and we're looking straight at them. And so this area here is the small bowel. This is the large bowel. And you'll see in this green colored area, this is the component of the small intestine that we remove to make the urinary reservoir, the ileal conduit that will expel the urine. So you'll see this. So this is a piece of the ileum. That's the bowel segment that we use. So we take a piece of the ileum out of the bowel, put the bowel back together, and then this piece of ileum is what ends up being the place where the urine goes, and then the urine comes out of the body. So this 15 centimeter piece that you're seeing was here. We use a bunch of staplers and other sharp things to remove this, put all this back together so you can eat and drink and everything like normal once you've healed from the surgery. And then this acts as the reservoir and will, because the bowels self-propulse, it'll push the urine out. And so when you have this type of diversion, we plug the ureters in, the ureters being the drainage tubes from the kidney. So the kidneys create the urine, it goes down to the piece of bowel. And then it sits in there until the bowel peristalsis and pushes the urine out. And it goes into a bag that I'll show you, and that's where the concept of continence comes in. This is some more pretty pictures of what we do surgically. So we, again, this is that area of the ileum, that area of the small bowel. So we take a little piece, We put the small bowel back together after we've taken our little piece, plug the ureters in, and bring it up to the skin. And this is what it looks like. Actually, this is a beautiful stoma. But certainly when you're not used to seeing these type of things, which most people aren't, and the concept of having a bag on your body, which nobody would want, are certainly things that cause people to be reticent and have lots of questions, which totally makes sense. So fundamentally, a non-continent diversion, an ileal conduit, correct. Any questions or anything? Keep going.
Keep going.
All right, so the Ferrari. So this is what's called a neobladder. So a neobladder is a continent diversion, meaning that we take a piece of bowel and where your bladder had been, and it goes to the urethra. Right now, if you have your bladder in your body, it's hooked to the back of your urethra. Your bladder squeezes, the urine goes out the urethra and comes out of your body. So this is meant to mimic that by creating a urinary reservoir that we put and sew to the back of the urethra. And you pee kind of by bearing down. What we mean, the technical term is valsalva. So almost as if you're trying to have a bowel movement, you kind of push down and the intra-abdominal pressure squeezes the neobladder and the urine comes out. So kind of similarly, we take a much longer piece of bowel actually. And what we do is we take this and it goes from a tube to a ball. And essentially there's multiple ways that you can do this, but fundamentally you cut it open. So it's open on one side. And then you start to sew it together, all the different walls of the areas that you cut, you sew it together and it ends up kind of looking like a ball. There's a lot of technical details that don't really fundamentally matter. But the end result is that these are those two urine drainage tubes. They hook up into the neobladder, which again doesn't have the same contractile function because the muscles are different and also not innervated. And then this is what ends up being, did I not put that one in? This is what ends up being hooked to the back of the urethra. This is a picture of another way that you can do it. So, you take your piece of bowel, you can cut it and sew it in a variety of different ways to make a ball that ends up passing the urine out. So this is just another way that we do it. This is called a Hauptmann neobladder. This is called a Studer neobladder. So you cut it, fundamentally you cut it, you sew it into a ball, plug in the ureters, and then the urine comes out of the neobladder when you valsalva. The important thing, if I was to get this surgery, is to know what some of the complications are, not only from having the bladder removal, but also the different types of diversions and what are some of the long-term things. But I mean, I will tell you that most of the patients who end up having this surgery, they stay in the hospital for about a week or so. There's a push in the bladder cancer surgical community to have patients go home sooner and sooner. And that's certainly dependent on how things go when you're done with having, once you're recuperating. And most of the time, the biggest thing that happens when you have this type of surgery is that you'll have gastrointestinal issues. So when you cut a piece of bowel and then sew it back together, those bowels kind of go to sleep and they'll wake up of their own accord. It's something that's called an ileus. And so a lot of times what ends up happening is patients will be doing well. The rest of their organs will be working well, but their bowels haven't woken up and they feel nauseous and they can't really eat until their bowels end up returning to their function. But certainly this is a really large operation. Depending on experience, it could take up from 4 to 8 hours. And one of the things I didn't mention, and it'll kind of be pertinent when we talk about what a nephroureterectomy is that you can do this operation open, meaning you make this incision, or you can do this in a minimally invasive fashion, which is robotically. We use a surgical robot to help with that. And there are pluses and minuses to doing each, and we can talk about that if people are curious. But at the end of the day, the goal when you have this type of operation, it's good to get people home within 5 or 7 days. The biggest concern, not the biggest concern, but the thing that most commonly happens is there's some type of GI issue immediately after the surgery. A lot of the patients who end up coming back will be dehydrated after. So it's really important when you have this type of operation to move around and be hydrated well. But when you have a big operation like this, it can be it's hard. You're tired, things hurt. But our overall goal is, and what I quote to patients is, we want you to be back at some version of yourself before surgery, ideally with around 6 weeks, but I used to be, overly or underly ambitious, I suppose we'll say 3 months. Like if I want someone to be back kind of where they were at most 3 months after the operation, but usually it'll be a lot better. So a lot of that is about the surgical management, like I said, of the bladder itself. We can talk about the upper tract, but if, like I said, please interrupt if there's any questions. I didn't go into like the chemotherapies, meaning, as Dr. Chandran was saying, we can give you systemic therapy, meaning medicine through the IV before the surgery, which is neoadjuvant therapy. We give you, depending on what your final pathology is, we can give you systemic therapy through the IV as an adjuvant medication. Sometimes we only do one, sometimes we only do the other, sometimes we do both. It depends on the type of bladder cancer you have and how invasive it is. But that's certainly a large component of surgical management is understanding when a patient's going to, I work so closely with Dr. Chandran and Dr. Apollo because when a patient has muscle invasive disease, we both have to really understand the timing of everything, because both of the therapies, when a patient can receive them, are very important. So we were talking about upper tract disease. So, again, the way that I simplistically think about this is you have your kidney. This is where the urine is made. You have your bladder. This is where the urine is stored. And then this little drainage tube is called the ureter, and that's where the urine that is made by the kidneys drains down into the bladder. And this can also develop urothelial carcinoma, and we call it upper tract disease. Now, in the same way that muscle invasive bladder cancer is, simple way to think about upper tract disease is the ureter, which is much smaller than the bladder, has a muscle layer. And so when it's, muscle invasive in the ureter, even though that layer is a lot smaller, that's when we consider removing the entire organ. Now, the one thing that's notable is you can have a tumor here, and people will ask, well, why do you have to take out my entire kidney if the tumor is here? And we can do certain types of surgeries where we will remove little pieces of the ureter, but the biology of this type of cancer and the way we diagnose it with these really tiny cameras, it makes it hard for us to be able to definitively say that only one area will end up having a tumor. And so a lot of the times, even though it might seem like overkill, especially because these little orange bars that you're seeing are also part of the collecting system and make the ureters, all of those areas are potentially at risk. And so we end up taking all of it out. But certainly, a question I commonly get is, well, why do you have to take out my entire kidney if the tumor's over here? But realistically, to be safe, we end up taking out the entire system. And so a nephroureterectomy is taking out the kidney and the ureter. So nephro, kidney, ureter, and then ectomy means to remove. And so you'll see here, this is the bladder. And then everything that is in green is what would come out when we do this type of surgery. And so we were talking about open surgery versus robotic. So for a nephroureterectomy, we typically do a robotic surgery, which is also a minimally invasive surgery. This is a cartoon showing kind of the trocars of the robotic apparatus that we use. And certainly in this type of disease state for a patient, I think it's much better to do a robotic versus an open surgery. And so, just some more cartoons when we do this, like this is imagining we're looking at somebody's kidney, and these here are the robotic instruments. So we go to where the kidney is, we open up and find the big blood vessels and staple them off so that the kidney no longer has any blood supply. You can see here the ureter that's coursing down. And then just like in bladder cancer, we end up doing a lymph node dissection so the kidney used to be over here. So we take out a bunch of the lymph nodes that are right under where the kidney had been. And then we follow the ureter, which is the drainage tube. We follow it all the way down to the bladder and remove the ureter in its entirety from the bladder. And then all of this is what comes out of the body.
One question.
Sure.
When would you do a partial nephrectomy?
So a partial nephrectomy, it would be different than doing anything for the ureter. So we'll do something that's called a partial ureterectomy. So partial nephrectomies are in relation to the kidney as opposed to the drainage area. So patients will have a kidney tumor, and that arises from, for lack of a better term, the meat of the kidney, and we'll take that out because it's a kidney tumor. Now, when it involves the ureter and the drainage tube, depending on where it is, and depending on A, where it is, B, how confident we are that it is only in the location where we think it is, and then there's a couple other factors, we will do things that are called partial ureterectomies. So you can do something that, if you're extremely confident that you have a tumor only in this area, you would do something that's called a segmental ureterectomy, where you would only remove the area that is, in theory, where the disease is. The most common thing that we do actually is we'll do something that's called a distal ureterectomy. And so what will happen is patients will have bladder cancer, and then they'll start to develop a tumor here in the area that is closest to the ureter, that's the closest to the bladder. And it's a lot simpler, and the biology of that type of tumor is much more amenable to just taking out this little part of the ureter. And so we do what's called a distal ureterectomy, meaning we just take out this part. But the concept of doing a partial nephrectomy is in relation to having a kidney tumor and not a urothelial tumor. But the concept of only taking out part of the organ is, also applies to this, depending on where the tumor is, if that makes sense.
Thank you.
So, we end up taking out the ureter in its entirety. Because this is a minimally invasive operation, patients will end up, they convalesce a lot faster. I would say most patients end up leaving the next day, or if not 2 days after. There are, we didn't really talk about all the tubes and stuff that come out of you once you wake up from surgery and how long they remain in your body. It's very dependent on the type of surgery that you get. But typically for an operation like this, you'll have a catheter into the bladder. So this is the bladder here. And you'll go home with a catheter in your bladder for 10 to 14 days and then get a special x-ray test to make sure that this hole that we sew up is closed and there's no leakage. When you have a cystectomy, depending on the way it's done and also the type of diversion that you have, there's a variety of different tubes that patients will wake up with. And it's easier to explain those when those specific drains are there. I can go into some of the new therapies that we're trying to utilize. So a lot of these, I think the ones that are the most studied are in patients who and we didn't really get into this, but when you have neoadjuvant therapy, there's a percentage of patients, 20 to 40%, depending on the series, that they get their neoadjuvant chemotherapy, they get their surgery, and after the surgery, they don't have any residual tumor in their bladder. That's what we call PT0, meaning there's no residual tumor in the bladder. And so that is a good prognostic factor, but that brings up the concept of, can we leave that bladder in the person if in theory they're cured by the systemic therapy? There's a lot of nuance to that. But we have a bunch of very expensive and fancy new drugs that have been developed in the last 5 years that go into the bladder, what we call intravesical therapy. And most of the time, these are being used in the non-muscle invasive space, but there are certain clinical trials that are using them in the muscle invasive space. And I think the one, not to go into too much science, that is the most, A, easy to understand, and B, the most studied, is this thing that's called the pretzel, which is what we call, it's called TAR 200. So it's a silicone tube. And in the silicone tube, there are gemcitabine. So that's one of the medicines we give both in a non-muscle invasive and a muscle invasive way. And this pretzel will sit in your bladder because it's a pretzel, and it won't come out when you urinate. And over the course of weeks, it will release this chemotherapy that's sitting in the bladder.
How do you get it in there?
So you put it in with a catheter, actually. So you pass this catheter in, and you can see the silicone tube here. It's not quote unquote fully deployed at this point, so it can easily go into the bladder. And then once you deploy it, you kind of pull a wire. It'll kind of,
Open.
yeah, transform, I suppose, and turn into the pretzel. And inside of the pretzel is this wire. It's what's called a nitinol wire, and that helps to keep its shape. And so over the course of 3 weeks, it'll release its chemotherapy, and then we exchange it by putting a cystoscope or a camera into the bladder and pulling it out and then putting a new one in. And
So you pull the wire out.
You actually grab the entire thing.
Oh.
So because it's silicone, it's actually pretty small. It's it's the size of a coin, like a quarter. Yeah. And because it's made out of silicone and this wire that's in it is really floppy, it's really easy to pull. But the way it's shaped, it doesn't come out, but it's easy to remove. And there have been some studies where patients will have this put in their bladder after they've had neoadjuvant therapy for muscle invasive disease as a way to try and see if any residual tumor, or if there's nothing there, can be controlled by having this instead of having a cystectomy. And all of these other drugs that I'm not going to bore you with that are all fancy new viral agents are also
the pretzel one, though. I read that the FDA just recently approved that one
on September 9th.
And is that gonna be readily available?
Yes. Yeah. Now, again, these drugs are all more for non-muscle invasive.
Well,
disease.
I'm a non-muscle invasive.
Yeah. Okay. Yeah. So I can kind of explain. That question requires a little bit of backstory that I'm happy to explain once we kind of finish this.
Okay, great.
And also, certainly, one of the things that I'll do when we're done is I'll have my contact information up, and we're federal employees or public servants. I'm happy to, I'll put my emails in this. I'll put my cell phone on there. Feel free to reach out if anybody wants to have a tele appointment.
But it's only approved for CIS with or without TA tumors, right?
Yes. So the technical approval indication for the FDA is CIS plus minus any papillary tumors. But from a clinical trial standpoint for muscle invasive patients, all of these agents are being studied in some fashion as a way of bladder sparing. And so, to the point of Dr. Chandran, we are trying to understand the biology of tumors that remain after receiving systemic therapy, through the IV, but also what agents can we use as a way to make it safe so we don't have to remove anyone's bladder. So this is the NIH hospital. This is my email. Like I said, I'll put it in the chat, and I'll also put my cell phone in there. Like I said, happy to talk, have appointments, whatever we can do to make it simple and try to explain these things. And Dr. Chandran had put this in here as well. These are, we were talking about Beacon before. If any. Certainly for
those are great resources. Like Beacon, Beacon is just fantastic.
So actually, I'll show you.
Education, and HOPA is a good source for chemo. If anyone's needing to undergo chemotherapy, it provides.
So this is the kind of book that Beacon has for patients, and these are readily available and downloadable. So if you just go to beacon.org, they have all these patient resources. It's a fantastic organization to partner with. And, it kind of explains some of the things that we've gone over. But certainly it's written, it has a lot more information about non-muscle invasive disease. There's information about diversions, and it's a fantastic other partner organization to try and answer questions and things like that. So I'm gonna, how do I do this? Stop sharing. There you go. So what can we answer? And if not,
I'm just going to quickly take the recording off in case people want to share something and not have it on the recording.